We know that many of our patients have spare puffers at work or at home. For this reason, it is important not to rely only on the medication record from the computer. Instead, the number of SABA puffs used per day allows an accurate calculation of the number of canisters used per year. We asked Judy, during the past 4 weeks, how many times daily? Knowledge check question 1. A patient is not in good control if using greater than or equal to how many salbutamol canisters per year? The answer is 3. Considering both the CTS and GINA The Asthma Right Care Slide Rule has been developed by the International Primary Care Respiratory Group to stimulate conversations about over-reliance on SABA. As mentioned, the GINA recommendations no longer recommend SABA-only treatment for Step 1, based on the evidence that SABA-only treatment increases the risk of severe exacerbations and that adding ICS significantly reduces the risk. The slide rule looks at the number of puffs of SABA a patient uses per day, or per week, or per year, and then calculates the number of SABA inhalers used by that patient per year. The most practical question would be to ask your patient, in the last 4 weeks, how often did he or she use his or her SABA in a day? We know that many of our patients have spare puffers at work or at home. For this reason, it is important not to rely only on Knowledge check question 1. A patient is not in good control if using greater than or equal to how many salbutamol canisters per The answer is 3. Considering both the CTS and GINA recommendations, patients should only be using a maximum of 2 canisters of salbutamol per year. The Asthma Right Care Slide Rule has been developed by the International Primary Care Respiratory Group to stimulate conversations about over-reliance on SABA. As mentioned, the GINA recommendations no longer recommend SABA-only treatment for Step 1, based on the evidence that SABA-only treatment increases the risk of severe exacerbations and that adding ICS significantly reduces the risk. The slide rule looks at the number of puffs of SABA a patient uses per day, or per week, or per year, and then calculates the number of SABA inhalers used by that patient per year. The most practical question would be to ask your patient, in the last 4 weeks, how often did he or she use his or her SABA in a day? We know that many of our patients have spare puffers at work or at home. For this reason, it is important not to rely only on the medication record from the computer. Instead, the number of SABA puffs used per day allows an accurate calculation of the number of canisters used per year. We asked Judy, during the past 4 weeks, how many times daily have you used your rescue inhaler? Judy tells you she uses 2 puffs of her rescue inhaler twice daily. Pharmacists can ask this question during counseling and on refills of SABAs or other asthma medications. The answer will allow you to use the slide rule. Judy states she uses 2 puffs twice a day, which equals 4 puffs per day. This equates to 7 canisters of SABA per year. 7 canisters of SABA per year is above the greater than or equal to 3 canisters of SABA. Therefore, Judy is not in good control and is at risk of exacerbations. We have assessed that Judy's asthma is not well controlled. How do we now as pharmacists intervene? There are several key educational messages that we need patients to understand. Number 1, asthma is a chronic inflammatory disorder of the airways. Number 2, regular use of controller therapy is important to control that inflammation and prevent flare-ups. And 3, controller therapy should be continued even if symptoms are well controlled. As per the CTS guidelines, spirometry showing reversible airway obstruction is the preferred method of diagnosing asthma. There are, of course, alternate options for diagnosis, such as a full pulmonary function test or a methacholine challenge. Does your patient have an asthma diagnosis? If the diagnosis is unclear, refer to their healthcare provider for spirometry or further assessment. Is the patient currently using controller therapy, for example, ICS, ICS-LABA, or LTRA for their asthma? If yes, assess patient adherence. If non-adherent, problem solve together with the patient as to why they are not using the controller therapy regularly. Is the frequency a challenge for the patient to remember doses? Is the patient experiencing any side effects? Does the patient dislike using medication when he or she feels well? If the patient is not using controller therapy, discuss the role and importance of controller therapy with the patient, relating it to asthma being a chronic inflammatory condition, and recommend appropriate therapy to the patient's healthcare provider with their permission. Assessing inhaler technique is extremely important. Pharmacists should have patients demonstrate how they use their inhalers. They can then help patients optimize their technique by demonstrating proper use and coaching them as they demonstrate back. Placebo devices can be kept at the pharmacy. It is very important to ensure that patients are able to inhale the medication into their lungs. For metered dose inhalers, spacer devices can be recommended if the patient is having trouble coordinating pushing down with breathing in slowly. Pharmacists can also recommend alternate devices to the patient's healthcare provider. When recommending alternate devices to the patient's primary care providers, consider: for the drug the patient is using, what types of devices are available for that drug or that class of drugs? Allow the patient to try various devices in front of you to assess effectiveness of actuation, adequate inspiratory effort, coordination, and physical limitations, for example, arthritis. The patient's preferences of devices is a critical consideration in selection of a particular device. Is the dose schedule convenient, and is the patient able to adhere to the schedule, for example, daily versus BID? Is the alternate device covered and affordable for that patient? Inhaler technique should be assessed and reinforced at subsequent visits to ensure that the patient is indeed receiving the medication effectively. Is the patient overusing SABAs? If yes, reinforce the importance of regular use of their controller therapy to control inflammation, prevent symptoms, and flare-ups. Assess triggers and environmental control. Avoidance of irritant and allergic triggers in the home, school, and our work environments is very important. Pharmacists have an essential role in helping patients identify and avoid environmental triggers specific to that patient. Some examples of common triggers or allergens include dust mites, molds, pollens, viral infections, air pollutants, smoke, cold air, physical activity, chemical fumes and other strong-smelling substances such as perfumes, and intense emotions. It's also important to consider if the patient is allergic to a pet at home. Are there any occupational exposures that are affecting the patient's asthma? Is the patient a smoker or exposed to secondhand smoke at home or in the workplace? And finally, does the patient suffer from comorbidities such as rhinitis, sinusitis, or GERD? Treating rhinitis and sinusitis with antihistamines or intranasal corticosteroids can improve asthma control. Uncontrolled GERD, when treated with histamine antagonists or proton pump inhibitors, can also lead to significant improvements in the patient's asthma control. Is the ICS at an appropriate dose? Does the patient require step-up therapy, for example, the addition of a long-acting beta agonist or leukotriene receptor antagonist? Make the appropriate recommendation to the patient's healthcare provider based on your patient. This slide is extremely important. Help patients understand what good control means and that uncontrolled asthma can lead to flare-ups, which can result in emergency room visits, hospitalizations, and even death. Form a partnership with your asthma patients. Ask them about their knowledge about asthma and how it affects their quality of life. Ask them about their goals for asthma control. What would they like to be able to achieve? Ask about their beliefs. What worries you about having an asthma attack? Ask about how confident they are that they can actually achieve good asthma control. And lastly, ask about their values, their desire for optimal health, not missing work, and supporting one's family. It's also important to identify whether patients have any concerns or barriers. For example, fear of using corticosteroids. Does the patient fear the side effects? Is the cost of inhaled corticosteroids a financial barrier? Asthma education should be delivered in small doses over a long period of time. Pharmacists see asthma patients often and can initiate dialogue during various encounters. Let's meet Shane. Shane is 32 years old, a non-smoker, and works as a financial advisor. Shane has called in a refill for his salbutamol MDI inhaler. You had flagged his prescription for counseling. His medication profile shows 5 salbutamol inhalers filled over the last year and no other inhalers on file. What questions would you ask Shane? Note too that Shane is not a smoker, but if he were, it would also be a good opportunity to advise Shane that quitting smoking would have significant benefits for his asthma. What questions will you ask Shane? The first 3 questions aim to confirm an asthma diagnosis. Why do you use this salbutamol inhaler? Or, has your healthcare provider told you that you have asthma? Shane answers, I have had asthma since I was a child. Have you ever had a breathing test? When was the last time? Shane responds, I remember having one, but not in the last 10 years. Note again that spirometry is the preferred method of diagnosing and monitoring asthma. How many times per week do you have symptoms? Not every day, but an average of 5 times per week. This question is assessing control. Although the profile states Shane has filled 5 SABAs over the last year, he may not be using all of them. Over the past 4 weeks, how many times per day did you need to use the salbutamol inhaler? Shane states, not that often, 2 puffs twice a day on the days I need it. This question assesses asthma control and will allow us to use the slide rule. Note that Shane comments not that often. He perceives his asthma is in good control. There's a disconnect between his understanding of his asthma control and his symptoms. This is an example of one of the paradoxes that was discussed in Dr. Ellis's presentation. Do you use any other inhalers? Shane states, no, this one works great for me. This question seeks to establish if Shane is on controller therapy for his asthma. Note the comment, this one works great for me. It illustrates that Shane perceives more benefit from his SABA, yet another paradox. Can you show me how to use this inhaler? You give the patient the placebo to demonstrate to you. Obviously here we are assessing Shane's technique. Shane is not shaking the inhaler and is breathing in before actuating the inhaler. In metered dose inhaler users, actuation before inhalation in 24.9% of patients was associated with uncontrolled asthma. Shane states that he uses 2 puffs twice daily, 5 times per week. This equates to 20 puffs per week, which amounts to 5 canisters per year. What would you discuss with Shane based on his answers? He has no recent spirometry to assess asthma. Patients should have had spirometry to confirm an asthma diagnosis. As well, patients should have spirometry performed periodically to assess lung function. It is important to mention this to Shane or to his healthcare provider. Note that the availability of spirometry in some communities may be a challenge. Shane is overusing his SABA. We need to address concerns with poor control and risk of exacerbations. He does not have an ICS or other controller therapy for his asthma to control inflammation. What are the preferred options as per GINA? Recommendations for Shane who has symptoms about 5 times weekly. Let's take a look at the GINA recommendations more closely. Let's look at Gina's preferred treatment based on symptom frequency. Shane is experiencing asthma symptoms more than twice monthly, but less than daily, which requires Step 2 therapy. Let's take a closer look at Step 2 in the Gina recommendations. Note that these recommendations are for adults and adolescents 12 years or older. This slide also emphasizes what are the preferred options as per Gina for Shane who has symptoms several times weekly. Note that these recommendations are for adults and adolescents 12 years or older. This slide also emphasizes the importance of personalized treatment and that treatment doesn't just mean medications, but also treatment of modifiable risk factors, comorbidities, and non-pharmacological strategies. You can see here that preferred controller and reliever options as well are stated for each of the steps. Let's look a little closer at the preferred Step 2 options for Shane on the next slide. What are the preferred options as per Gina for Shane who has symptoms several times weekly? There are two options for preferred controller: daily low-dose ICS or as-needed ICS formoterol. Both choices are appropriate options. Consider patient preference with the device and note that Shane did have difficulty actuating the MDI. Note as well that only budesonide formoterol 200 over 6 micrograms is indicated PRN. Budesonide formoterol received approval in Canada as an anti-inflammatory reliever in September 2019. However, note that both strengths of budesonide formoterol can be used for SMART, single maintenance and reliever therapy. The other combination therapy of a fast-acting LABA in Canada is mometasone and formoterol, which has not been approved for use as a reliever. Other controller options include LTRA or low-dose ICS taken when SABA is taken. If Shane's healthcare provider chooses ICS formoterol PRN, then budesonide formoterol would also be his reliever. If, however, Shane's healthcare provider chooses daily low-dose ICS or LTRA, then SABA would be Shane's reliever. Keep in mind that budesonide formoterol PRN can only be used as the reliever when budesonide formoterol is used as the maintenance or PRN medication for that patient. What if Shane was only having symptoms less than twice per month? There's only one preferred controller in this case: as-needed ICS formoterol. Again, only budesonide formoterol 200 over 6 micrograms is indicated for PRN use. The alternate controller option would be low-dose ICS taken with each PRN dose of SABA. Again, this is off-label. Individualizing therapy and patient preference is critical to adherence. For example, if SABA PRN is chosen as his reliever option, adding a spacer to the MBI may not be practical for him to carry around. The pharmacist can educate and ensure that he can use the MDI without the spacer effectively, or give him other options such as terbutaline or ICS formoterol PRN. I would like to highlight a very important point. Although Gina recommends as-needed ICS formoterol, which in Canada is budesonide formoterol, as a preferred reliever across the whole spectrum of asthma severity, this does not apply to all patients in steps 3 to 5. The use of as-needed low-dose budesonide formoterol with other combinations of inhaled corticosteroid and long-acting beta agonists, such as fluticasone propionate and salmeterol, fluticasone furoate and vilanterol, or mometasone and formoterol, is not recommended, as the safety and efficacy has not been studied. For these patients, SABA should be the preferred reliever. Therefore, low-dose budesonide formoterol is the preferred reliever only for patients in steps 3 to 5 who are prescribed maintenance budesonide and formoterol therapy. What would you discuss with Shane based on his answers? We have established that Shane is not using a salbutamol optimally. We can recommend a spacer. We do need to teach technique and have patient demonstrate back. And we need to ensure that he can effectively use an MDI with or without spacer. Discuss that asthma should be assessed by his physician. Due to his frequent symptoms, he needs controller therapy. We should also ask permission to send a fax to his physician and encourage Shane to make an appointment. We should also ask Shane if he would like links to websites that provide asthma education and tools. Another note, if the primary care provider changes his inhaler to budesonide formoterol PRN, the pharmacist should ensure that Shane can use the DPI effectively. This is an example of a fax that was sent to Shane's primary healthcare provider. The fax outlines that Shane's asthma is not in good control as per the CTS guidelines and the 2019 GINA recommendations. He is using SAB on average 2 puffs BID 5 times per week and has used 5 canisters of SAB in the last year. The fax also addresses the need for controller therapy. Spirometry to monitor his asthma is also mentioned. The fax ideally could go on to recommend preferred options for Shane, such as low-dose ICS formoterol PRN or ICS daily plus SABA PRN. Once you create a fax, save it as a fax template to save time, where you can insert the patient's information for each intervention. Written action plans are the foundation of guided self-management of asthma. Asthma action plans help patients recognize and respond to worsening asthma. Patients monitor increases in their symptoms and/or decrease in their peak expiratory flow. The asthma action plan gives direction to step up therapy, such as increasing controller and/or reliever medications, starting oral corticosteroids, and when and how to access medical care when asthma is worsening. This plan should be regularly reviewed by the patient's healthcare provider. Examples of step-up therapy can be found both in the CTS 2012 guideline update and the GINA 2019 report. This is an example of an adult asthma action plan. Asthma action plans can be downloaded for free from the Lung Health Foundation website, formerly the Lung Association. Pharmacists can facilitate the use of an action plan by giving the patient a copy to bring to their healthcare provider. As well, pharmacists can collaborate with the patient's healthcare provider to fill out the action plan or fax a suggested action plan for approval or discussion. Knowledge check question 2. List the 2 options for preferred initial treatment for an asthma patient who experiences symptoms less than twice per month. Recommendations, the 2 options are 1. As needed use of low-dose ICS formoterol, or 2. Low-dose ICS taken whenever SABA is taken. Let's look at some clinical pearls about how after today you can be an asthma coach and SABA guardian for your asthma patients. Assess. Knowledge check question 2. List the 2 options for preferred initial treatment for an asthma patient who experiences symptoms less than twice per month. In recommendations, the 2 options are 1. as-needed use of low-dose ICS formoterol, or 2, low-dose ICS taken whenever SABA is taken. Let's look at some clinical pearls about how after today. Knowledge check question 2. List the 2 options for preferred initial treatment for an asthma patient who experiences symptoms less than twice per month. Recommendations, the 2 options are. Let's look at some clinical pearls about how after today you can be an asthma coach and SABA guardian for your asthma patients. Assess all refills on a SABA. Questions you can ask when filling a salbutamol inhaler include: has your healthcare provider ever told you that you have asthma? Have you ever had a breathing test or spirometry? Do you have any other inhalers at home? In the past 4 weeks, how many times per day would you say you use your salbutamol inhaler? Patients using greater than or equal to 3 canisters per year is an incredible opportunity for intervention. Use the asthma control check as a quick and useful tool to assess asthma control. Attach it to the prescription bag and flag for counseling. The asthma control check can also be given to the patient to complete while they're waiting for their prescription. Patients can also take the asthma control check home, complete it, and bring it to their healthcare provider. Assess and review inhaler technique. Consider expanded scope pharmacy services, such as medication reviews or smoking cessation. Whenever possible, provide evidence-based recommendation to the patient's. Knowledge check question 2. List the 2 options for preferred initial treatment for an asthma patient who experiences symptoms less than twice per month. Recommendations, the 2 options are. Let's look at some clinical pearls about how after today you can be an asthma coach and SABA guardian for your asthma patients. Assess all refills on a SABA. Questions you can ask when filling a salbutamol inhaler include: has your healthcare provider ever told you that you have asthma? Have you ever had a breathing test or spirometry? Do you have any other inhalers at home? In the past 4 weeks, how many times per day would you say you use your salbutamol inhaler? Patients using greater than or equal to 3 canisters per year is an incredible opportunity for intervention. Use the asthma control check as a quick and useful tool to assess asthma control. Attach it to the prescription bag and flag for counseling. The asthma control check can also be given to the patient to complete while they're waiting for their prescription. Patients can also take the asthma control check home, complete it, and bring it to their healthcare provider. Assess and review inhaler technique. Consider expanded scope pharmacy services, such as medication reviews or smoking cessation. Whenever possible, provide evidence-based recommendation to the patient's healthcare providers. By providing clinical recommendations, it is an opportunity to demonstrate to other healthcare professionals the important role we as pharmacists play on the patient's asthma care team. Don't underestimate the power of brief interventions. Identifying a patient with asthma who is not well controlled and intervening can significantly improve a patient's quality of life. Document the patient's asthma and any identified drug therapy problems in the computer profile. Make a deal with your patient. Suggest a patient who is not well controlled and non-adherent to ICS to try using the ICS regularly for 2 months. Set up a phone call reminder 2 months later to see how he or she is feeling. In most cases, patients will report a significant beneficial change in their asthma, which paves the way for adherence to their controller therapy. Reinforce the importance of ICS to prevent flare-ups and asthma. After this presentation, set small incremental goals for yourself. Pick one thing you're going to change, do it for 2 to 4 weeks, and then when comfortable, consider adding another brief intervention. A great way to start is, for the next 2 weeks, I will ask every patient with a SABA the following question. In the last 4 weeks, how often have you used your rescue inhaler? After 2 to 4 weeks, I will refer all asthma patients who are not well controlled to their physician, or take it a step further and intervene with a fax outlining why the patient needs to be assessed and recommend the appropriate therapy. In summary, we know that asthma is a chronic inflammatory disorder of the airways, and that patients need to understand that controlling inflammation is key to preventing symptoms and flare-ups. You have learned several strategies to assess control of your asthma patients. The next step is to partner with your patients who are not well controlled and develop shared goals. As a key member of the asthma care team, intervene with your asthma patients' healthcare providers to facilitate reaching these shared goals. Regularly assess and review inhaler technique, asthma control, adherence, triggers, and comorbidities. Brief interventions with asthma patients in your daily practice can reduce the number of asthma-related hospitalizations, emergency department visits, missed days of school and work, and deaths. Patients enjoy significant improvements in their quality of life and general well-being. And as a pharmacist, seeing these positive changes in your patients is incredibly rewarding. The next few slides are excellent resources for pharmacists and patients. All of these resources can be downloaded for free from the Lung Health Foundation, formerly the Lung Association. At the time of this presentation, the Lung Health Foundation website was being updated with more resources. The Lung Health Foundation has also updated the respiratory medications reference. The next slide is a very helpful resource for pharmacists. This respiratory medication resource includes several useful medication tables, including information on age, maximum dosage, and coverage. Inhaler devices and nasal sprays are included as well. I truly hope that you've enjoyed this presentation today and that you recognize the potential you as a pharmacist have to help your patients optimize their asthma control, prevent exacerbations, and most importantly, enjoy a higher quality of life. Thank you for listening.